Welcome to City Club of Portland's Friday Forum. I'm Lisa Watson, President of the City Club's Board of Governors. For more than 100 years, the City Club of Portland is where civic-minded people come together to make Portland and Oregon a better place for everyone to live, work, and explore. We're gathered today at the Sentinel Hotel and welcome all of you joining us via KGW's website, Facebook feed, or news app, X-Ray FM, or on Open Signal's community media television stations. A special welcome to all of the OHSU students who are watching us today live from their classrooms. The generous support of City Club's media partners and corporate sponsors enable us to put on the state's best civic programs week after week. I'd like to recognize City Club's fall sponsors, Avangrid Renewables and Morel Inc. I'd also like to thank Oregon Health Sciences University and Interstate Bank for their support. Please show your appreciation. I am pleased to welcome a distinguished panel with deep experience working with patients throughout Oregon. Today they'll talk about the healthcare challenges they're seeing in rural Oregon and discuss opportunities to provide better care to people across our state. Our panelists include Bruce Goldberg, a Senior Associate Director at the Oregon Rural Practice-Based Research Network at OHSU. Bruce previously served as the Director of the Oregon Department of Human Services and as the Founding Director of the Oregon Health Authority, where he supervised Oregon's implementation of coordinated care organizations. Also on the panel is Liz Powers, the Innovations Director and a full-scope family physician at Winding Waters Community Health Center in Enterprise. She previously served on the American Academy of Family Physicians Commission on Rural Health and is the past president of the board of directors of the Oregon Academy of Family Physicians. She's currently on the steering committee of the Oregon Rural Practice-Based Research Network at OHSU. Moderating our discussion today is Serena Cruz, the executive director of the Virginia Garcia Memorial Foundation. The Virginia Garcia Memorial Foundation supports healthcare for Washington and Yamhill counties with a special emphasis on migrant and seasonal farm workers. Serena is also a former Multnomah County commissioner. Please welcome our speakers.
Well, good afternoon, everyone, and good afternoon to these two venerable doctors. Is it okay if I call you by your first name, Bruce and Liz?
Please.
Yes, okay, please. Great. Well, I'm Serena Cruz, and I'm really excited to be with you this morning. You know, we're sitting here in this venerable room at the City Club of Portland, and I think folks might wonder why the three of us should be here talking about rural healthcare. Can you talk about why you've got some credibility on rural healthcare issues, and what brings you to that? What drives your passion to work on those issues? Bruce, go ahead.
Sure. Well, you know, Serena, it's interesting. I grew up in New York City, which doesn't seem like the best credibility for talking about rural health care. But I'm a family doc, and I began my clinical career actually practicing in a frontier area in New Mexico for 6 years. So worked a lot in that arena, and then came to Oregon and have had a lot of experience working with Oregon's rural communities through a lot of the jobs that I've had, and most recently through the Oregon Rural Practice-Based Research Network. We work with over 100 practices in rural areas all throughout the state, working to improve rural health and helping to support those communities, providing technical assistance and a variety of other endeavors to help improve the health of our rural communities and to support rural practitioners like Liz. And so through that, have had a lot of opportunity to work pretty closely and intimately with our rural communities.
That's very exciting. Liz, can you tell us about yourself?
Sure. So my childhood experience is pretty much the opposite of Bruce's. So I grew up in the Upper Peninsula of Michigan, the daughter of a family doc. And I think that really shaped how I understand medicine to be and what it means to be a doctor and to care for a community. And so as I was going through my medical school training and trying out a lot of different areas of medicine, I realized that to me, I needed to be a small town family doc, and was able to find in Enterprise a community that I could connect to. And so I have my particular corner of Oregon that I know really well, but I also work as a practice transformation consultant for the Oregon Health Authority, and so get to travel around and see the amazing things that other rural clinics are doing across the state, and remain connected as well through the practice-based research network that Bruce mentioned.
That's great, Liz. I think that we've demonstrated some credibility here, and as for me, I grew up in Eugene, Oregon, so it's neither a small little town nor is it New York City, but it's not particularly rural. My brother, though, however, with his family, lives on the southern Oregon coast between Bandon and Port Orford. For those of you who know it, it's Langlois. And in their community, rural community, high-speed Wi-Fi isn't available. They've got just a little bit better than dial-up there. The closest hospital is nearly an hour away in Coos Bay, and it isn't hard to imagine that living in that sort of community and that density, while open and wild, also creates its own challenges. And we know that 1 in every 3 Oregonians lives in a rural or a frontier community. What do you think makes life different in rural Oregon? Bruce.
Well, let me start and give you sort of a high-level perspective, and then we'll let Liz sort of drill down to her community. When you look at nationally, about 15% of people in the country live in rural areas. In Oregon, as you mentioned, Serena, it's about 36% of our state lives in a rural community. And that means that you're more than 10 miles away from a population center of 40,000 people. And we have about 12 counties in the state that are frontier counties, meaning that's even more rural than rural. And a frontier county is a county where there's less than 6 people per square mile. And in these communities, from a healthcare perspective, tend to have a lot of all the things you don't want to have, and not as much of the things you'd like to have. So what we know is that people that live in rural communities tend to be older, they tend to be sicker, and they tend to be poorer than the rest of our state. And that's juxtaposed against not having enough medical care. So fewer doctors, fewer dentists, fewer nurses, tremendous shortages, large numbers of communities without mental health care providers, without dentists, often traveling large distances for health care. So a lot of real challenges in our rural communities.
So Enterprise is in Wallowa County, which is one of those frontier counties where a population of 2.2 persons per square mile, so that's really small. There are no stoplights in the entire place, and we're 330 miles from the nearest cath lab. So really isolated in that sense, and we are the oldest county in the state and aging faster than other counties in the state. So like Bruce said, a lot of those are real barriers. I think transportation, connection to the internet, and ability to access specialty services are things that we really struggle with. And I think on the flip side, one of the benefits of a small community is that you really are connected to the medical care that is present there. And so there is not the fragment of care or sort of the multi-specialty care that you sometimes see in a larger place.
How many physicians are there in Wallowa County, Liz?
Sure. So right now, there are, I'm counting their names on my hand, I think there are 7 of us. And people might say 7 physicians for 7,000 or a bit more people seems like too many, but know that the physicians in Wallowa County take care of the clinic, the hospital, the emergency department, all the OBs. And so we really are sort of spread across multiple care environments. I take care of my patients wherever they need me, whether that's in their home, in the hospital, in the ER. And so we look at our physician per person in a different way.
Can you speak more to that? And I'd love to hear your perspective too, Bruce, after Liz, about kind of what those care environments look like in rural communities. So you said that do you have a physical office?
Sure. So we do have a physical office and we have a hospital, and I would say I really do believe that they're state-of-the-art facilities. They were built by a community that was really invested in healthcare. So we have top-notch facilities, but a lot of the care that we provide is outside of those facilities as well. So in people's homes, in the assisted living facilities.
How many miles would you drive between to see your patients?
Sure. So I do house. I think the furthest away I've done a house call was 65 miles, but most of the time it's within a 25-mile square radius. We also have we call it the HOW van, or Health on Wheels, and we partner with our county mental health agency to do a traveling clinic that goes to the sort of outskirt communities that aren't the main population centers of Wallowa County.
Bruce, is that what you're seeing in other parts of the state as well?
Yeah, yes, very similar. I mean, there are a lot of great facilities,
Yeah.
a lot of modern offices and hospitals. I think there are a couple of issues. Or one, when it comes to some of the technology, there's certainly issues around Wi-Fi and high-speed internet in a lot of communities that keeps people connected. There's certainly issues around getting some of the technology to communities because of the economies of scale in providing certain services in a variety of communities. And then there are communities where there just aren't any services. There are the Office of Rural Health, which does some really great work and publishes great information about healthcare in the state, has divided the state up into over 100 what are called primary care service areas, where you can draw a circle, and that's the area in which people have looked to as their community for medical care. There's about 25 of those areas where there isn't any primary care, where there isn't any dentist. So I think where there is, it tends to, it's great. There are great practitioners and really good facilities, but the issue is that there are large numbers of places where there just aren't. And I think Liz just came up with a great new definition for counting the rurality of healthcare, where you can you count the number of doctors in a county on your hand? I think it's a great new statistic.
Agreed. Liz, when you're visiting your patients, what are the kinds of health problems that you're seeing them have, or when they come to you either way? What are you seeing that you think is different, and then what's more of the same, like we would experience in the city?
Sure. I actually might answer this question a little bit through the eyes of the OHSU residents that rotate out through us. We've been a teaching site for OHSU residents for more than 25 years, and all of them rotate through Enterprise for 6 to 8 weeks in their second year. And what I hear from them about the differences between providing care in Portland versus in Enterprise is that our patients are sicker, and they have more chronic conditions, multiple at the same time, and that they are surprised to see rare conditions pretty frequently, that they weren't expecting that in our community. And I also think that they're surprised by the way we provide care. So what I will take care of in the hospital, or what I will do as a direct admit from home to the hospital, rather than putting somebody through the emergency department.
Can you explain that a little bit more?
Sure, yeah. So a patient who, for instance, has flank pain and is seen in the office for that, we wouldn't send them through the ER for their kidney stone if they needed to be admitted. We would either manage it in the office with some IV fluids and some Toradol and take care of their acute pain and keep them there for a couple hours and send them home. Or if they needed to be admitted for pain control, I would just walk them over to the hospital, and I would be taking care of them just in a different setting.
Exactly. Bruce, is that very similar to
Yeah.
what you've seen and heard?
Yeah, and I think it really illustrates the real concerns and problems in rural communities. Because on one hand, we've got, as Liz said, patients are a lot sicker. We know, for instance, that the deaths due to suicide, due to cardiovascular disease, due to cancer, due to diabetes, tend to run 40 to 50% higher in our rural communities than in our urban areas. So a tremendous burden of illness and sicker individuals, and that's juxtaposed against fewer providers, less of the socioeconomic supports for communities and for people, which are really important to help make them better. So it really is a big problem.
Yeah, there seem to be a lot of challenges. I'm going to take a quick moment to remind our broadcast audience that this is City Club of Portland's Friday Forum. I'm Serena Cruz, and I'm speaking with Doctors Bruce Goldberg and Liz Powers about rural healthcare in Oregon. So what both of you said in response to that last question reminded me and resonated deeply with what we see out at Virginia Garcia. So we're serving, a rural and an urban population mix, but in the summer, in particular, we have a mobile clinic that goes out to migrant camps and to nurseries, and there we do see very complicated health situations and folks who haven't been seen by primary care providers, some in years, and how good it feels and how it makes a difference in people's lives to be able to access care. Can you talk about the difference that it makes in people's lives in rural Oregon? What does healthcare mean? What does it mean for them? Liz, would you like to?
So that just resonates with me. So one of the things we know about Wallowa County, it's a ranching community and a logging community, and people have been there for generations, and there's intergenerational poverty, and there's a lot of family pride, and so people don't come in for healthcare. And especially didn't come in for healthcare when they didn't have coverage. So we have a lot more people who are self-employed, or a lot more people who are seasonally employed, working for the Forest Service or fighting wildfire. And so the story that sticks in my head is being on a ski vacation with some friends of ours, and recognizing that one of these friends was actually in a funny heart rhythm, but hadn't sought care for this because didn't have coverage or health insurance. And so one of the things that we've seen lately with the expansion of coverage with the ACA and expanded Medicaid population is that people are coming in for care that haven't had care before, and their ability to access care is really changing lives for them and for their families.
Exactly. Bruce, I wanted to step in for a moment into some of the other challenges that we're seeing before we move into solutions that are possible in the state for responding to some of these problems. But it seems like we haven't addressed the challenge of hiring providers and other folks in the medical profession in these communities. What are we experience this barrier in a huge way at Virginia Garcia. We've got a school-based health center in Willamina, Oregon, and Willamina is a community outside of Sheridan, about a half hour away from McMinnville, where it's only 1 square mile either direction, and we have a school-based health center there that's open to seeing all members of the family, but we can't keep a full-time primary care provider there, and the clinic in Sheridan just closed. It's a huge challenge. So what are you seeing in other parts of the state? Is this only a Yamhill County kind of concern?
No, what's seen around the state is Yamhill on steroids, so to speak. Huge challenges in recruiting and retaining healthcare providers across the board. This isn't just about doctors, it's about mental health professionals, it's about nurses, it's about medical assistants. It's the entire healthcare team. So it's a big challenge for all of our rural communities, and we've focused on, we've been talking about those that don't have any doctors, but it's really the entire healthcare team. Now, having said that, there have been some successes in the state in being able to improve that. OHSU has a number of programs to train medical students and residents and others in rural areas to give them exposures to that, which helps attract people. We have a number of loan repayment programs and loan forgiveness programs in the state that are run out of the Office of Rural Health to help attract and retain providers in rural areas. There are some tax credits that are provided to rural practitioners, but despite all of that, it's still a real challenge and getting more so every day.
Yes. Liz, does housing supply and affordability affect the ability to keep medical and healthcare providers and support employees in Wallowa County?
Yes. So my two new doc partners who are married couldn't find a place to live in Enterprise actually at all. There were just no rentals available. And one of our partners was able to make a house available to them sort of off the market. And so you make it do. You make do with what you have, and the community helps. But that's a big challenge. I think there are a couple of additional challenges. We talked about the certified professionals like dentists and mental health professionals and doctors and nurses, but I think we also struggle with the other members of the team, so like medical assistants or community health workers, and there certainly aren't any certification programs or ability to get them out. And so we know, or what I have learned with my younger partners moving into our community, is that practicing in a team-based setting is what is going to allow them to do what they do. They need to be able to turn off the faucet. They need to be able to share some of the care with other team members or with other providers. And so creating systems that value other team members and pay for other team members to make that financially viable in a practice in a community is important.
Those are great issues to bring up, and I'd like to go into them just a little bit more. Bruce, could you speak to what it means to provide care in a team setting and what some of the payment components are in our system that are supporting team payment?
So I think we've been seeing as medical care evolves that it's not all done by one person, that there's a whole team of individuals, that it's not just simply about an office visit with a health professional, it's about care coordination in between those visits. And unfortunately, a lot of the payment around medical care has focused around when you only see that particular office visit. It often doesn't support the telephone calls, the care that's being done via internet, via email, the care coordination activities, visits by community health workers at home. I think we're fortunate here in Oregon that we've begun to change some of that, and that through our care coordination organizations around the state and through others, that payment is now being directed more at some of the things we haven't paid for, like home visits. Some of the care is for the being provided to an organization to be able to deliver that kind of care coordination, and that helps. But there's still a long way to go. We still have a fairly visit-focused way that healthcare gets paid for.
Exactly, and I think we see the same thing at Virginia Garcia, and our providers say exactly what you say, Liz, that providing care in a team means that you get support. There are things that folks are better at than providers. If somebody wants to quit smoking, bringing in the behaviorist is a great way to help someone make the changes they need to make in their lives in order to change that, versus the provider who can certainly tell them it's bad for them and gives them good ideas, but without a team, it's hard. So clearly, bringing together a team is challenging in any environment, but even more challenging in the rural environment. Let's talk about what some of the solutions are to these challenges in rural healthcare and kind of I know one of them we're looking at is telemedicine and teledentistry, and that is one that isn't particularly fostered or supported yet by the insurance industry, and I think they'll get there. But can you talk about any experiences you guys have had with telemedicine or dentistry, and what difference that might make in in your communities?
Yeah, so we have a robot. And
a robot.
We have a robot. And
Does the
since
robot have a name?
No. We talked when we got it about giving it a name and dressing it up with clothes to make it a little more accessible to patients, but we found that they knew what it was, even under disguise. And so we use our robot for a couple of different things. We actually do telepsychiatry, and that has been huge in expanding access. We don't have a psychiatrist that lives in our community. We do have a social worker, an alcohol and drug counselor, and a behavioral health coach in our clinic, but having psychiatry support has been really important. We also use the robot in different ways, partnering with OHSU as part of their ECHO program, and expanding the capacity of our providers who are in the community to provide a higher level of care for patients, and really broadening their scope to enable them to do more, I think has been the most impactful.
Bruce, do you want to explain a little bit more about ECHO?
Sure. ECHO is a tremendous program that helps expand the sort of team-based notion of care around the state. What ECHO does is provide a forum for practitioners to come together and work with a specialist around a particular healthcare problem, whether that's mental illness or hepatitis C or diabetes. And it allows practitioners from all around the state to get together to share cases and to be able to gain from the experience of the expert in the field, and then to sort of expand that knowledge throughout the practice. So it helps provide access. If you think about it, what it does is it helps provide access to specialty care through a local primary care provider who's connected in a meaningful way to that specialist through video and weekly sessions. So it really can help a lot to improve access to care. I think one of the issues that you've mentioned is, we don't, rural practitioners don't get reimbursed for the hour and a half that they may spend a week in those kinds of settings. So we need some policies that help get the resources to communities, and vice versa. We have a lot of rural communities that are seeking to do a lot more in telehealth, but there's no one at the other end. And I think you've probably experienced that as well, where communities are making investments in the technology to do telehealth, but then, and they've got the equipment, they have the patients, but there's nobody on the other end, and that's because of some of the challenges that we have around, meaning the state and the nation as a whole, about how that gets reimbursed and how that gets organized. So the good news is that we're all learning and starting to move that forward, and I think, as Liz said, we can start to see some of the fruits of that.
And I hope that some of the payment changes will drive some of that, but I think some of it is a cultural change as well. I thought it would be a barrier to my patients to not want to see a specialist over the robot, and so far that has been less of the case, though certainly with their regular doctor they want a relationship. But they've been grateful to not have to travel 3 hours to see a specialist one direction. I think the harder thing is that the specialists that I have reached out to still have a sense in their mind that they need a in-person relationship with a patient in order to provide care. And so we really have, even when the systems are in place, like at OHSU, or we work with another system, the Catholic Health System in Washington, and they actually use telehealth regularly, but there are departments where we can't access it because the physicians aren't there.
There's so many potential barriers and challenges as we get through all of this. And I need to take yet another break here to address our broadcast audience. This is City Club of Portland's Friday Forum. I'm Serena Cruz, and I'm speaking with Doctors Bruce Goldberg and Liz Powers about rural healthcare in Oregon. And when you were both discussing the challenges involved with telehealth, it reminded me of this latest experiment that we ran at Virginia Garcia, where where our dental director and the dental clinics director were both responding. They're both dentists, and they were responding to folks in the field trying to view films and that sort of thing. And we were running into two problems. I mean, one was the Epic itself wasn't yet programmed to be able to do that, and that's the medical record piece that we use in both dental and medical, and then making sure that the person was on the other end of the line, as you said, Bruce, because here she is, the dental director, juggling 10 million other things at the same time and trying to find the way. And it struck me that burnout is a huge issue in the field generally, but must be even more challenging in rural communities. Is that something that you're seeing or feeling, Liz? Do you see people stay?
You know, I think there are communities where that is the reason there are no providers. And I think that is absolutely a challenge, especially in our modern environment. So when I went to Enterprise more than 10 years ago, I would pack up my box, literally a milk crate of charts, and I would drive them to the clinic and I would see my patients, and it was just me. And it's a really different setting now with our fully functional care team and CHWs and full-time clinical pharmacist and all of the mental health support and a full-time dentist. I feel much more supported, but I also have an electronic health record that requires my attention and doesn't give nearly as much back to me as my interaction with my patients, right? So I think that our transformed care has brought with it some challenges that lead towards burnout, and I think being alone and isolated in a rural environment can sometimes exacerbate that. I do think on the flip side, the relationships that you build with your patients in your community there can be so intensely rewarding. We actually just did this within our community health center. We did a burnout scale for all of our staff, including all of our providers, and I think you could score 50 was the least burned out and 0 was the most burned out, and I think I scored a 49. So I'm very rewarded by the relationship that I have with my patients in my community. So I think there are both huge challenges and huge opportunities, and I think unfortunately the communities that are struggling, the challenges are even worse.
That does tell a critical tale, though, that even with your level of satisfaction, you're still scoring very high on that scale. Is that similar to what you see, Bruce?
Yeah, I think the issue of, it's not just physicians. I think of professional burnout is a big problem that we're starting to recognize nationally and it's not just rural. As we have people that go into the healing professions to be healers and to interact with people and to have a meaningful part of their lives, are finding that both the advances of our technology also interfere with some of that some of the administrative complexity and a lot of the intrusions of the technology and a lot of the payment and administrative issues really interfere with that. And electronic medical records are wonderful things, but if you start to talk to physicians about their relationship with their electronic health record, it's a love-hate relationship. And this really is it's a growing problem. And then as Liz said, I mean, this just, it's a problem throughout the country, and then it's exacerbated in rural communities where that margin of reserve, I think, is less. And whereas we started off, there's just fewer providers, so you're doing more and are even more involved. And I think it's a real issue.
Yes, that makes a ton of sense. Before we turn to the issue of insurance and Medicaid, because I think we can't have this discussion without talking about that. I would love for each of you to articulate what are the top 2 or 3 policy changes you would like to see take place to address some of the things that we're experiencing right now in rural Oregon. Bruce, do you want to start?
Yes, let me start with an idea that may be a little bit new to the state. They're actually looking to pilot this. Thank you, Serena. Pilot this in Pennsylvania, but it's the idea for rural hospitals, which we haven't talked a lot about today, but really are critical to communities and face a lot of financial instability and need assistance. But it's a way of creating what would be a yearly global budget for rural hospitals that's contributed to by all of the payers in the state, the insurers and Medicare and Medicaid, and a budget that's sufficient enough to allow that hospital to be sustainable, to allow it to make some of the investments in the community, and to create some predictability and sustainability of the hospital in the community. So I think if we look at a different way, we talked a lot about payment before, but I think that we need to create the kind of stability in payment and in resources that allows not just physicians and nurses and other health professionals, but hospitals to stay in business. So that's one thing I'd love to see us start to look at to create in the state.
Just a quick follow-up before we get to your solutions, Liz. So when you describe this support for rural hospitals and care providers, does it look like a different kind of rate for per member per month if that's what it is, or is it what would the tools be to make that happen?
Well, it looks like a yearly budget that's sufficient enough to sustain the hospital, and I don't know exactly how they pay that out, but it alleviates the issue around the fact that 2 or 3 admissions one way or another can really affect a hospital's financial viability. And so being able to kind of create that sort of stability, I mean, the devil's in the details with a payment that's sufficient, but that will make it so that there can be some reliability in a community, really important.
Interesting. Liz, what would you like to see? What policy changes?
Sure. So I talked a little bit before about how important the team is for being able to both recruit and retain providers and also avoid burnout. I think one of the things that we've seen in this state is that the coordinated care organizations are making strides in that area, and yet that isn't necessarily across the board with other insurers, and certainly isn't necessarily the case for Medicare. So we have a large population of Medicare patients, 35%, and we also in our little clinic have over the last year billed 133 different insurers and 152 different insurance plans. And so, I have a colleague who talks about, instead of single payer, could we at least have single payment? So we're not jumping through hoops with each different company, and some of which value a team and some of which don't, and can't, like Bruce said, be predictable about whether we're going to get the resources we need to really take care of that community. So I would say some standardization and recognition of what's needed to provide care in sort of this transform model. And then I think the second piece is really about access. We've seen in this proud rancher community what a difference it makes to have insurance, and how that can absolutely reduce ER costs and hospital admissions. We're sort of this little microcosm, right? Nobody leaves the community. It's the clinic and the hospital, and we've seen a 5.4% reduction in our hospital rates when we were able to expand our coverage and get people to just come in for primary care.
Great. Bruce, you wanted to add something?
Yeah, I just wanted to add something we haven't talked a lot about, and I think it's germane around the payment piece, which is that there's more to health and being healthy than just a doctor or a hospital or a nurse or a medical assistant or a robot or an x-ray. It's also about our social environment. And it's about things like housing, it's about food insecurity, it's transportation, it's jobs, it's a variety of issues.
Childcare.
In fact, studies show that many of the social factors are probably better predictors of our health than our access to medical care. So when we look at policy solutions, I think some of the policy solutions for healthier communities isn't just let's throw more healthcare providers at communities, but it's how do we be certain that people who have mental illness have a stable living place? How do we deal with some of the issues of raising people's economic status? And we've started at some of that through our coordinated care organizations to start to be able to help create the bridges between the social and the medical side of things. But I think there's a long way to go, but I just felt we needed to mention that as part of the discussion, really important.
How we couldn't talk about social determinants of health in a conversation about healthcare in this state is, yes, thank you. Thank you very much. So we're going to turn briefly to insurance, and I really want to be transparent with you and with the audience that this last month, both the Virginia Garcia Memorial Health Center and the foundation boards endorsed Measure 101 because we believe that everyone deserves access to health care. And for those in our audience who might not be familiar with Measure 101, it's a legislative referral we're going to vote on very soon, January 23rd, 2018, and it provides an assessment on providers and hospitals that will ensure that hundreds of thousands of Oregonians continue to get Medicaid. And these are working families and their children. So at Virginia Garcia, we think that 9,000 of the 45,000 patients we serve, their insurance is at risk. And so if access to care wasn't already complicated by all of the things that we were talking about, this measure in our state, we believe at Virginia Garcia, and I would love to hear what you guys think, will have a big impact on our communities. So we're voting yes, but yes. What are you thinking, Bruce?
Well, I think as we've been speaking this entire session, it's really been about, one, the fact that rural communities are sicker, poorer, older, have less providers of health care, and we know that there's a higher percentage of people on Medicaid and Medicare in our rural communities than commercially insured. And the communities really rely on Medicaid for access to care, not just communities, but individuals, and that if we see an erosion of that coverage, it's going to, in our rural communities, take an even more precarious solution and make it harder. I mean, it simply means that there'll be more people who are uninsured, less dollars that come into that community to support that care. And so I think it would be really detrimental to the health of not just our communities, but to many individuals who would lose coverage.
Liz, do you have some thoughts about Measure 101?
So in our community, the expanded Medicaid population about doubled the number of community members that were on Medicaid. And so if we are no longer able to have that expanded Medicaid population, about actually more than 10% of our population will lose coverage. So that will really hit home. We've seen who that population is. They're the ones who didn't have any health care when they showed up a few years ago, and now have been engaged, and we're working on preventive health, and we're getting their diabetes under control. And so I know personally who those individuals are, and sort of the risk they have for wild swings in those chronic health conditions.
Great. We're going to actually turn now to our audience. I know you've all been waiting for this moment to arrive. So if you've got a question on an index card, please hold it high for the staff to collect. You can also submit questions through Twitter using the hashtag Friday Forum. I'll try and read at least one index card question and one from Twitter. And while we invite City Club members to ask their questions from the microphone, not while, we do invite you to ask your question from the microphone. So please identify yourself as a City Club member and ask one question in, this is key, 30 seconds or less. And so I will interrupt you if you go on too long. I'm just warning you in advance. And I can't see you because of the lights. So I assume that somebody is standing there in front of the microphone.
Actually, a couple of us are.
Okay, great.
Jim Zarin, City Club member. My question is, I don't think I heard the word federal in the sense of the U.S. Senate and the U.S. House and the White House. I don't know what happened today, but as of last night, I think our tax bill pending in the Congress is going to gut Obamacare, and I'd like to know what the impact would be on your lives and your patients' lives if that bill passes and is signed by the president.
Liz, would you please speak to that for your perspective? And I think we can each add some more.
Sure. So I have to say I'm a bit confused by the tax bill.
Shocking.
I hope I'm not the only one. But what we do know is that the destabilization of the Affordable Care Act actually has already impacted us. Our uninsured rate was 13 to 15 I'm going the other way around, was about 19% before the ACA expansion and stabilized at less than 5% for a good 3 or 4 years. And then in January has started climbing and has continued to climb and is back up to 13% uninsured rate. So we know that even uncertainty about what's going to happen, let alone a change in the law, actually does make an impact.
Yes, we're seeing the exact same thing that Liz is seeing. So we were at 40% uninsured prior to healthcare reform. 20% was our stabilized level, and we're back up to 25. And Bruce, I assume, consistent?
Yeah, statewide. I mean, federal policy, I mean, thanks for bringing it up because it has a huge impact on the state. Mm-hmm. And the Affordable Care Act really helped improve the lives of a lot of people in the state and helped us move from where between 10 and 15% of our population didn't have insurance down to about 5%. I think the whole theme of this conversation today has been that's 10 to 15% that didn't have insurance statewide, but it's been higher in our rural communities. So the Affordable Care Act has had a really tremendous impact on our state, getting many more people health insurance, and any kind of threat to that will change that.
We'll take one more question, and then I'll turn to a card.
Thank you. My name is Sally Bachman, and I am a City Club member. If you could expand your answer to the last question to cover rural hospitals and Virginia Garcia, so health centers. My understanding is that before the ACA expansion, rural hospitals were having a really hard time keeping their doors open and were closing their doors because of the cost of caring for uninsured patients. And I wondered how many hospitals in Oregon were in that situation, were closed or on the verge of closing before the ACA. And so if the ACA expansion, and if the ACA expansion is reversed by Congress, what percentage of hospitals would be on the verge of closure? Thank you.
Bruce?
Yeah, I don't have the exact percentage, but I think what you said is correct in terms of, you know, the big difference between hospitals and everyone else is that, you know, unfortunately what we know is that some people, when they get sick, if they don't have insurance coverage, they end up not going to the doctor. But when they get really sick and need to go to the emergency room or have a traumatic injury or have a heart attack or a variety of real emergencies, people don't forgo that. They go to hospitals. And fortunately, our hospitals and our rural hospitals take care of those people. When you've got 15, 20, 30% in some communities of the communities uninsured, that's put many of our rural hospitals at tremendous kind of financial peril. And the Affordable Care Act has really helped with that. Has it made things perfect? No, we still have a lot of rural hospitals that have precarious finances, but I think if you go by community, every single rural hospital has been strengthened by the Affordable Care Act because of the fact that our hospitals don't turn people away, they take care of people. And the more people that are insured, the better that is for the individual, for the hospital, and for the community.
Yes, I would just echo all of those statements and just add that for us as a federally qualified health center, we're feeling just the lack of certainty in every arena. So there's the lack of certainty about the ACA and Medicaid. There's a lack of certainty about the federal grant that we get that helps cover a percentage of the costs that we get for seeing uninsured. And that grant has yet to be reauthorized. The House passed the bill, but the Senate hasn't passed it yet, and so we're over the cliff, so to speak, and we're worried. That could be 5,000 patients for us that we get some support for to see. And then on top of that, we're looking at expanded Medicaid being lost if Measure 101 doesn't pass. So it's a very tenuous time right now from state and federal perspectives. So thank you for that question. So I'm going to take a question from the card and then I'll return to the microphone. So PAs and NPs, that's physician assistants and nurse practitioners, are playing a bigger role in our healthcare system. How are they helping you meet your workforce needs? Liz?
Sure. So we have both physician assistants and nurse practitioners in our office and in our community, and they're really a vital part of the team and are there and available to see patients. I think they absolutely expand access for our community, and they do great work. They're super people, and they're excellent providers. I think the struggle in rural communities, especially rural communities that have hospitals, is just that the scope of practice needed is sometimes greater than those advanced practice providers can provide. So they don't, for instance, cover the hospital or the ER or deliver babies. And so in some ways, our ratio of doctor, MD, or DO to person is higher in rural areas and needs to be because of the scope of practice.
Right. Bruce, did you have?
I think nurse practitioners and PAs are great. They help expand the workforce, particularly in a lot of our rural communities, but also in our urban areas. But we're also learning that other health professionals can do more and more of the types of things that we used to rely on physicians or nurse practitioners to do. Much of the education, preventive services, a variety of the things can be done by other team members, and it really is about creating that team that can act efficiently to deliver care.
And just from Virginia Garcia's perspective, we are hiring more nurse practitioners and physician assistants than medical doctors, in large part because there's a larger supply of them, and we do see them as providers when we refer to all of our providers. So it's a critical part of our team. We'll go to the next City Club question.
My name's Kathy Moyd. I'm a City Club member. I just recently went on the Casey Eye Institute's mobile eye exam van trip to Eastern Oregon, and one of the things we had was a lot of migrant workers who, one of our questions was what kind of insurance you had, and most of them had no insurance, and also most of them also had diabetes. Right. And I'm just wondering, one reason why I'm assuming you can't get to 100% insured is because of lack of ability to cover the migrant workers, the undocumented ones. And I assume that also has an effect on your hospital costs, that they frequently end up in the hospitals. So I'd like your opinions on that, and do you think there's anything we can do about it?
So as Serena was mentioning, I think that's one of the roles that the community health centers have played. So Winding Waters is a community health center as well, and are available to our community to take care of anyone who walks through the door, regardless of whether they're documented or not, or whether or not they have coverage. But that's not available in all rural communities, and there are a lot of challenges to becoming a community health center. And as Serena mentioned, the funding for those safety nets is in jeopardy right now. So I think that is a problem, and maybe one of the things that we need to add to our policy list of things that should change.
So I would just add to that something we can build on, because I think you're absolutely right. A large proportion of those without health insurance now are those who are not documented citizens. Having said that, this past legislative session, our legislature passed a bill to be certain that all kids, regardless of their citizenship, can get basic health care. And so that's been a policy solution that should be applauded, absolutely. And it also is one that we should look to perhaps build on, because of exactly some of the things that you've witnessed and that we see in our state every day.
And I agree completely with Liz and Bruce, and just want to thank you for being on that Casey van and taking that critical care out to the rest of the state. Yes.
Ted Kay, City Club member. I heard a good news, bad news statement in what you were describing. In the area of telehealth, both having patients be able to access medical care remotely and also have your medical facilities access specialists, say, in the big city remotely. And that was the good news. I hear great things about what's being done. At the same time, you described the bad news of the telecommunications infrastructure. Can you describe how that gets in the way, how bad the news is, and what you see as the prospects of reconciling those two?
Excellent question.
So I think that we are making great strides in sort of the hardware and the software components. We've gone through a couple of different HIPAA secure Skype versions, and we were in Jabber for a while, and then we went to video. And so I think we're learning, and in a rural community, you do a lot of learning. I think it's a great site for pilot and spread. And because it is something that we really want to connect to, we're willing to put in the extra effort to do some of those early trials. So I think the hardware and the software piece is getting a lot better, though the computer was down yesterday. It doesn't always work perfectly, especially with the getting internet at appropriate speeds. And I will just add to that I think patients are patient as well. They know that this is saving them a huge car trip, and so when the screen freezes up and you have to reconnect, people aren't angry at the computer. They're willing to sort of sit with you and reconnect. I think the harder piece that we haven't gotten to is what's the incentive for the providers and the systems on the other end. And we had to work through a huge contracting process with OHSU to start on this endeavor. And it's complicated. And big organizations have lawyers and can help with the contracts, but they may or may not be willing to do it. And certainly rural communities don't either have the knowledge or capacity. And then there's the cultural piece, which is getting specialty providers in a tertiary care setting to care enough about the rural community to be willing to do that and to be willing to put up with a couple of hassles of the disconnect. I find it's not the patient that gets mad when an IT problem happened, it's actually the provider.
But I think also you point to the public policy solution, which is investments in whether it's the hardware, the software, or it's the high-speed internet across communities. It's very expensive. And we can't look at that kind of an expense being borne community by community, because in rural areas, these are small communities that don't have the resources and economies of scale to invest in, as we see in a lot of our larger areas. And we see many of our large health systems in urban areas making lots of investments in a lot of this because they can. But we don't see it in rural areas. It's much more of a challenge, and it's because we've looked to every community to solve their own problems. And I don't think this is one that we can, from an economic standpoint, look to every community to solve for themselves. There needs to be a statewide and a national policy solution.
Thank you. Well, that is all that we have time, all the questions. I'm sorry we didn't get to the last question that was standing there. Please come up after and ask it. And I really want to thank Bruce and Liz for joining us today. Thank you all, and I'll hand it back to Lisa.
Thanks,
Thank you, Serena.
Thank you.
We are out of broadcast time for today and have to stop. If this program's inspired you to join or contribute to City Club, you can do so at the registration table as you leave the room. This is Lisa Watson from City Club's Board of Governors. Thanks once again to today's program sponsors, OHSU and First Interstate Bank. Thank you to our special guests, and special thanks to Sam Metz and the Friday Forum Committee for their hard work. This program is adjourned.